friends, INI CET November 2024 just got over, and I'm sure that you're all eagerly waiting for the recall session. I'll be dealing with PSM. I'm Dr. Rajasi, your PSM faculty. As far as PSM is concerned, I could get around 14, 15 questions from PSM in the first or in the initial few hours, and students were a little bit confused because from same topic like malaria there were multiple questions, so they were like, I think it is complicated, I think it is uncomplicated case, and few were like, even I'm confused, like what is the exact question. Anyways, whatever I could get I have collected, and if you have any more questions to share, you can share it under the comment box, or else you can even directly ask me. This is my WhatsApp number. Okay, this is my WhatsApp number and this is my Insta ID. Either through Insta or through WhatsApp, you can always ask me. I'll get back to you with the answer. And like I said, few questions were confusing, and answers, questions were not confusing exactly. The answers were key in the sense that you can rule out two, or, you know, what you can rule out, okay, this won't be the answer. This also can't be the answer. But the other two were very confusing because both could be the answer. It depends upon the way you think. Sometimes there'll be some catch in the question which will help you to understand, okay, so this is the most probable answer. So most probable answers were the ones we had to choose this time. So let's start with the first question. This was very simple. I thought I'll start with something very simple so you won't be scared. Which of the following is not part of the program? So the question, sorry, of Anemia Mukt Bharat program. Okay. The question was about Anemia Mukt Bharat. I just took the question that students gave me and they said, Madam, this question was about Anemia Mukt Bharat. Okay. So what is the answer? This definitely, I'm sure everybody would have got it correct because we have discussed umpteen number of times the answer. This is known as 6 into 6 into 6 strategy, right? Under which we have 6 beneficiaries, 6 interventions, 6 institutional mechanism, whereas 6 health facilities. Some said 6 programs. I don't know which was the exact correct answer. Anyway, A, B, C are actually part of Anemia Mukt Bharat, whereas the answer here would be 6 health facilities. Okay, we have already seen this is the logo of Anemia Mukt Bharat, and it is also known as Intensified Iron Plus Initiative. And in this logo, you will see a drop of blood and 6 people standing. I hope you can make out. This 6 has a relevance because there are 6 beneficiaries, 6 institutional mechanism, and 6 key interventions done. And the 6 key interventions which are done to reduce anemia, I have given in this particular picture, which you can go through. I will not be going into the discussion part. This is a recall session and I'll be giving you the insight. Okay, why this is the answer, why this is not the answer. Because as you can see here, there are 6 interventions. These are the 6 interventions, not just giving iron folic acid, treating the malaria in endemic pockets, giving deworming, that means albendazole tablets. A lot of things are there. Then delayed cord clamping. These are 6 interventions. So when you count 1, 2, 3, 4 karke, you will definitely get 6 interventions. Okay, 5, 6. Then 6 beneficiaries. What are the 6 beneficiaries? Do you remember? I have given you a table. I will not be going to the details of the table because there are many MCQs hidden in that table itself. And I said these are these 6 beneficiaries for which we are giving iron folic acid. 2 are children. Can you see? Then here I have grouped them into 2 special category of women. But if you look at this closely, when I was discussing this in class, there itself I have said it is women in the reproductive age group, and here the women pregnant and lactating I have clubbed into one single table or under one single category. But actually, pregnant is one and lactating women is another. So that makes it 1, 2, 3, 4, 5. And in the middle, you have 10 to 19, which is adolescents. So that covers those 6. Okay. And we have discussed this in our class. So I will not be going into those details. We also have 6 institutional mechanisms. which I said you don't need to remember all those 6 institutional mechanisms, but just understand that there are 6 institutional mechanisms. Nobody will ask you. I mean, so far they haven't asked, and I hope they will not ask because that is not that much relevant for us. What is more important is what are the 6 interventions which we can do as doctors, and what are the 6 beneficiaries, or who all are the 6 beneficiaries for which we are giving these interventions. Okay, I hope it is clear. So the answer was D. Moving on to next. Very simple, very, very simple. There couldn't be any doubt at all. Which among the following is the best study design? What do you think? This is based on evidence pyramid. When I started my discussion for study design, I actually started off in class with something like this, right? And I said, this is evidence pyramid. This is, you call it as evidence pyramid. That means it is a pyramid-like structure in which various study designs are arranged. As you move up the pyramid, I said the strength of evidence that you get, or the power of evidence that you get from each of the study design, increases. And I said in the top, you have meta-analysis, and meta-analysis is known as gold standard study design. Standard study design. And this is the best study design. Okay, so naturally, what will be the answer, guys? It is meta-analysis. So here the answer is meta-analysis. I don't think that requires any more explanation. Okay, so meta-analysis is the best, followed by second would be RCT, third would be this one, and fourth would be this one. So this is the best. Just in case they had asked about arrange it in the correct order, then this would have been, because that type of question has also come earlier. Next, this was confusing. Which of the following malarial tests is used for diagnosis? Little bit confusing. Okay, so anyway, thick smear, thin smear, will come to that. What is this HRP2? This is nothing but your rapid diagnostic test kit, RDK or RDT, whatever, rapid diagnostic test kit. There in HRP, it is, what are you actually detecting? It is a histidine-rich protein 2 antigen in the blood to identify malarial infection. This is what you are testing. And this Buffy code is nothing but, see, the QBC. That is quantitative Buffy code test, which is again a laboratory test that is used for detecting malaria. Okay, can be used for other diseases as well. Anyway, these we use. Along with that, thick smear, thin smear, again, that is also used for detecting malaria. So each of this is a test that you use for testing malaria. And which one do you think is the one that we use in the field? Many wrote RDT. Of course, we use RDT, but you know what the program is saying? NVBTCP program says that whenever possible, go for smear. If smear is not available, or if there is no specificity for doing microscope or microscopy, then you go for rapid diagnostic test kit. Okay, and this is something which is you know, so this we can rule out because there is smear given. And QBC is something which is not easy to do in field. We don't do it in the field. So that is also out. This is out. This is out. Now we are left with just two, thick smear and thin smear. Honestly, both are done in field. So definitely you will have a doubt whether to go for thick smear or thin smear. But when you read the question is, which one will you do? Which is the one that is used for diagnosis? Okay. So let's see what is the specialty of thick smear and thin smear. Tick smear is done to detect the presence of parasite. To detect the presence of parasite. That means whether parasite is present or not. It is determined using thick smear, because thick smear will be having around, almost 20 times more blood than what you have in thin smear. Then what is the use of thin smear? Why are you making thin smear? That is for species identification. And based on species identification, you give the treatment, right? So if you think that way for diagnosis, it would be thick smear, is it not? So the answer would be thick smear. Okay. Moving further, again from malaria. Students were asking me, Madam, all these are, which among the following is not used in complicated malaria? Okay. There is one more question that was even more confusing in malaria. This is kind of okay. Okay. Which drug is not used in complicated malaria? In complicated malaria, we usually don't use chloroquine, right? Whereas artemisinin we use, sulfadoxine we use, as you know, sulfadoxine pyrimethamine combination. Once the patient start tolerating the parental oral drug, then you can give ACT. Quinine, even that is also used, whereas the answer here would be chloroquine because we don't give chloroquine in complicated malaria. Only in uncomplicated cases, we give chloroquine. Okay. Now, when it comes to complicated malaria, don't you guys know that initially complicated, mostly the patient will be having some cerebral symptoms and the patient will not be in a state to take anything orally. Okay. So you can't give chloroquine at all. Okay. And then what you do was the point is initial 24 to 48 hours, you have to give parenteral treatment. So for parenteral treatment, mostly you'll give either quinine or some artemisinin derivative. And after that, once the patient starts tolerating the drug, that means oral drug, then you can switch over to area specific ACT. Okay. So all these can be given. Area specific ACT has sulfadoxine pyrimethamine. So this is given. This is A is given, B is given, D is also given in complicated malaria. So the one which is standing out, which cannot be used in complicated malaria, or as per the guideline, this is not recommended, which is chloroquine. Moving on to the third question from malaria. Again, one more question from malaria. Which of the following is not used in the treatment of uncomplicated malaria? What is the answer? What did you write? This was a question, the second question from malaria that was confusing because all these we give in uncomplicated malaria, right? Chloroquine you give for PV. Sulfadoxine pyrimethamine you are giving in ACT combination, right? Artemether is given for patients from Northeast. Primaquine, of course, we are giving. So all are given. And we have to definitely find one answer from this. So what would be the answer? We know that chloroquine you are giving for Plasmodium vivax. Sulfadoxine pyrimethamine we are giving as part of ACT kit. Primaquine, of course, we are giving for 14 days in PV as well as in PF we give primaquine. There is no doubt about it. Now, what is artemether? We know that artemether is something I said you give if the patient is having PF malaria and if the patient is coming from Northeast, right? There we are giving artemether lumefantrine, right? Here, it is just artemether. Just artemether. That means artemether is usually given as monotherapy only in complicated cases of malaria. Whereas when it comes to uncomplicated cases, you give artemether lumefantrine combination, right? That is ACT-AL is what you give. That means monotherapy is not given in artemether if it is an uncomplicated case of malaria, whereas A, B, and D are given for uncomplicated. So let's go with artemether here. Are you convinced? Next question, again from mosquito-borne disease. Which of the following is not good for Zika prevention? Now, how is Zika? What is he? How is someone getting Zika? Mainly through mosquito bite, right? Mosquito bite, especially Aedes mosquito. We know that it is mainly through Aedes mosquito. And Aedes mosquito, when it bites a pregnant woman, then it can cause complication. What complication? As you can see in this picture, see this Aedes mosquito. Name is also important. Aedes mosquito. Okay, Aedes mosquito is biting a pregnant woman, and Zika infection is getting transmitted, and it is affecting the brain of the fetus, leading to what is happening? Microcephaly. Okay, that means From this, you would have understood two different modes of transmission. One is, it is a vector-borne disease. It could even be vertical transmission, right? From mother to fetus. So two modes of transmission are definitely present. One is vector-borne and the other is, mother to fetus, vertical. There are few more other methods by which Zika virus can get transmitted from one person to another. Apart from mosquito and from mother to fetus, sexual contact is also possible because the this organism can remain active in the semen. So from one person, another person can get disease through sexual transmission. Then blood and blood products, organ transplantation. It is said that Zika can be transmitted through even organ transplantation. Then lab exposure. Zika can be transmitted in lab setting as well. Now let's just go back and see what would be the answer. I'm not very sure whether these were the options given. Honestly, I don't know because I got many options and this is what majority said. So based on this, I will have to choose one answer, right? If you have any other options with you, please let me know. Okay, it's a disclaimer. I'm not very sure whether these were the original options given. Which of the following is not good for Zika prevention is the question. Sexual abstinence using condoms and birth spacing needed. Of course, there is a sexual route, so this can be used for Zika prevention. Zika vaccine. If there is a vaccine present, we have some candidate vaccines, but we don't have any pakka vaccine, which is the vaccine for Zika. We don't have anything like that, but of course, we have many candidate vaccines. Zika symptoms managed by NSAID. Then plasmapheresis for neurological complication. Yes, plasmapheresis is given for prevention of neurological complication. For prevention of neurological complication, uh, we do plasmapheresis because one of the neurological complication is like Guillain-Barré. So many problems can be caused because of this Zika infection. So for preventing that, we do plasmapheresis. So there also plasmapheresis is doing some prevention. Whereas Zika symptoms, do you think Zika can get? We have already seen how the disease is getting transmitted, right? If I have Zika, because of my symptoms, is it possible for another person to get Zika? No. Symptomatic treatment is only for me. If I reduce my symptoms, I cannot say that that will help me to prevent or that will help me to prevent transmission of disease from one person to another. Are you getting the point? That is only for the treatment of that person. That do not have anything to do with prevention. Whereas all others definitely has some stake in prevention. Okay. So let's go for option C. Again, I would like to say I'm not very sure whether these were the options given. According to the option that I have received, I would like to go for C. Okay. And if I'm getting any other options and if I am getting more light into these options, definitely I will let you know. Another simple question. Percentage of eligible couples in India at present. We know that eligible couple. You of course know what an eligible couple is, right? A married woman or a married couple where the woman is in the reproductive age group, which ranges from 15 to 49, right? Any idea how many eligible couple are there in India? As per the latest study, it is said that around 150 to 190. Okay, there are 150 to 180 or 190 eligible couple per thousand population in India, per thousand population. Okay, so what will be the percentage of eligible couples? That will be 15%. Okay, another question which came for the first time. I haven't seen it coming before, but we have discussed it in class. What is it? ICER. I think the question was ICER. They have not given the full form. It is an economic tool used for evaluation in. You guys know what is ICER? Okay, many got this correct. You know why? Because they just related CE and CE here. And when I explained this in my group, in my WhatsApp group, many were like, oh, hooray, I got it right. Then I asked, how did you know that? So they said, yeah, ma'am, we just guessed. See, here and there. So this could be the answer. Because I always say, as the name indicates, something has to do, the question will have some relationship with the answer you think. And you got it right. Well done, guys. Now let's see what is ICER. ICER, there is a full form. It is an incremental cost effectiveness ratio. Incremental cost effectiveness ratio. If you know the full form, definitely again you will be able to answer it correctly. Incremental cost effectiveness ratio. It is something which is used to compare the cost and effectiveness of different healthcare interventions. Okay. And it is a ratio that compare difference in cost between two interventions to the difference in cost between their effectiveness. So it is calculated by dividing the difference in the cost in the numerator divided by difference in the outcome or effectiveness in the denominator. Okay. So this is what ICER is. So ICER is for cost effectiveness, cost effective analysis. Okay. And in cost effectiveness, we know towards the input side, you have money, and towards the output side, you have the effectiveness. That means the results that is achieved in natural units, like the number of lives saved, number of diseases prevented, number of hospitalization prevented, is what you have in the as the output. So this is the formula for ICER. So you have two different interventions, and you want to compare the difference in the cost in the numerator and difference in the effect in the denominator. So this is the formula for ICER. So the answer is cost effective analysis. Next question is about vaccine. Actually, there were three questions from vaccine. Which of the following is not a live vaccine? It's a very simple question, and I heard no one got it wrong. First, which is not live vaccine. What about rota vaccine? Yes, this is a live vaccine. We know it's an oral formulation and it is given as 2 ml to child under UIP. What about varicella? Varicella is for chickenpox, right? This is for chickenpox. And again, that is a live vaccine given as 2 doses with an interval of around 8 weeks. And measles, again, like vaccines, under UIP, it is available as MR vaccine, right? Measles and rubella, both are live vaccines. And you also know the schedule, right? At the completion of 9th month and thereafter between 16 to 24 months. These are live vaccines. What about hepatitis B? Hepatitis B is an inactivated vaccine, right? Look at this. It is an inactivated vaccine which has surface antigen, right? And I think I don't have to tell you the rest, you know about it. HPS, hepatitis B, surface antigen is the recombinant surface hepatitis B surface antigen, and it is administered intramuscularly. So this is not coming under the definition of live vaccine. So which is the answer here? Hepatitis B is the answer. That was a simple question. Next question. I really don't know whether this was the question. Vaccine-preventable diseases. Not diseases. I think it has to be malignancies, right? The question I got, maybe cancers or malignancies, whatever. Okay. Vaccine-preventable cancers are all except. You told me this was the question. Okay. And they also said, few others told me this question was there, but the answer was multiple choice. Okay. Then they said, which among the following are vaccine preventable cancers was the question. Then you can go for multiple choice. And they said there were options like A, B, something like that. And according to them, the answers or the answer is CA cervix and HCC. Right? We know that there are vaccines available. If the question had been like, whichever the following are the cancers which can be prevented by vaccine, according to them, the answers were A and B. Then that is the right answer because we know that for CA cervix, we have the HPV vaccine. And for hepatocellular carcinoma, we have hepatitis B vaccine. Right. Now the question, suppose the question was like this. Vaccine preventable cancers are all except. Then you have to pick one, right? So definitely A and B will not come under the answer because we know that they are definitely preventable. What about Burkitt's lymphoma and Merkel cell carcinoma? For Merkel cell carcinoma, I hope you know what these are. If you don't know, just have a look at this. I'm not going to read it. Burkitt's lymphoma, it's a non-Hodgkin B cell lymphoma, whereas Merkel cell carcinoma, it is an aggressive skin cancer which occurs when the Merkel cells in the skin grow out of control. These things you know, right? Okay, now coming back to our topic proper, which is about the cancers which are preventable with vaccines. If you compare Burkitt's and Merkel cell lymphoma, for Burkitt's, we don't have any vaccine available, whereas for Merkel cell carcinoma, we have some candidate vaccines, okay, which are kind of licensed. If you're asked to choose one from these four, where we don't have a vaccine, it would be Burkitt's lymphoma. Okay, so I'm again telling you there were two school of thoughts for this particular question. Like few students told me it was vaccine preventable diseases. Which among the following are vaccine preventable diseases? And they said there was a multiple answer A and B. Then A and B will be the answer. Or else we have to choose Burkitt's lymphoma. What is the answer? Which vaccine is not given in age more than 65? This also I've taken in class. Under adult vaccination. There was a topic, adult vaccination, under which we have clearly seen which all vaccines can be given in more than 65. So which one? We'll start with HPV. What is HPV? We've seen it just now. It is for CA cervix. Not only for CA cervix, there are many conditions in which you are giving HPV. For malignant as well as non-malignant conditions, for boys as well as for girls, you give it. But it is not given after 65. We'll see the schedule after some time. What about pneumococcal vaccine? Yes, pneumococcal vaccine can be given for more than 65. In chronic conditions, as well as the second indication is more than 65, you give pneumococcal vaccine. This is the 2024 CDC guideline. Okay, so they say after 65, you have to administer either PCV 15, 20, or 21 for all adults more than 65 who have never received any pneumococcal conjugate vaccine or whose previous vaccination histories are known. If we are using PCV 15, earlier it was said that after 6 months you have to give, or after 1 year you have to give PPSV 23, right? But now they say that that should be according to a clinical decision. If there is a need, you can give PPV SV 23 after giving PCV 50. Nowadays, we are not using PCV 30, but instead we are using PCV 50. This is from 2024 guidelines because very recently, for more than 65, above 65, CDC says don't give PCV 13. Instead, you have to give PCV 15, 20, or 21, preferably 50. Okay, so this is about pneumococcal vaccine. That means that is given. What about the next one? Herpes zoster. That was shingles vaccine. Yes, there is a recommendation for more than 50 years. And it is given as 2 doses, right? 2 doses of 0.5 ml subcutaneous. If you are giving, there are some vaccines where it is 0.65 ml. Okay, anyway, second dose should be given 2 to 6 months after the first. So that is also given. What about influenza? Yes, influenza should be given every year. Whereas HPV is given only for those who are sexually active and ideally it should be given before the sexual activity starts, right? And it is given for both males and females. And the schedule is 9 to 14. It is given as a 2-dose series, 0, 6 months. And thereafter from 15 to 26, it is given as a 3-dose series. It is sometimes given up to 45 years, but again, that should be according to clinical decision. So as per the guideline, it is mandatory, or I would say it is recommended only for the age up to 26 years. Okay, so here the answer is HPV. Okay, what's the answer? Strategies good for COVID-19 prevention are all except. What is the answer? For COVID-19, when we were having COVID-19 pandemic, you all were familiar with something known as SMS, right? What is it? SMS. SMS kiya kya? That was the question, right? So first is S is soap or sanitizer you have to use. So for sanitizer, M is mask, and the next is social distancing. Now let's go back to the answer. Our options were ivermectin, mask, quarantine, vaccination. So we know mask was there in SMS. Social distancing is nothing but quarantine, right? That means, okay, of course, social distancing has something beyond quarantine, but quarantine was also done as part of social distancing because if you have any uh, if you are a contact of a positive case, you were asked to sit inside home and not to go and mix with the public because again, you have to distance yourself from the society. So that is also coming under social distancing. What about vaccination? Yes, vaccination is again something which can prevent COVID. What about ivermectin? No, that is not given for prevention of COVID. That has nothing to do with prevention of COVID. This was one of the medications which were available for, oh, I would say which were recommended, not recommended, which were suggested. Okay, suggested for COVID-19, but it doesn't have any FDA approval. So the answer, guys, what is the answer? It is ivermectin. Ivermectin has nothing to do with the prevention. Arrange in the correct order. This is from epidemiology. Arrange in the correct order. By the way, which study design is it? This is from RCT, randomized control trial. And the options were randomization, blinding, inclusion, exclusion criteria, and statistical analysis. By the way, guys, what is randomization? In randomization, you are taking a group of patients, you are randomizing them or dividing them into two arms of almost equal size. One arm is known as the treatment arm, next is known as the control arm. To the treatment arm, you are giving your drug of choice, and to the control arm, you are giving either placebo or some other standard treatment that you're giving in the ward. Then you are following them to see the outcome. And the outcome is taken in the form of some statistical analysis. Okay, your effectiveness, then intention to treat analysis. So many things we are finding out at the end of RCT or at the end of trial using some statistical analysis. So definitely that is what you do last, right? Then now what about randomization, blinding, inclusion, exclusion criteria? You know what? Before you randomize, first you have to add some inclusion and exclusion criteria, like who all will be included and who all will be excluded. Okay, so there are some inclusion criteria and exclusion criteria based on which you first select your sample. And I can show you a diagram which is from Nowhere But Your Park textbook. So first you select a suitable sample, then you take out those who will not come under your inclusion criteria. So those who are not eligible should be taken out. Then you do randomize, divide them into two arms, like I am showing here. Then while giving treatment, you are doing blinding. Okay, so blinding is something that has something to do with you or the patient receiving the drug. Okay, so when it comes to, allocating the treatment, comes blinding. Then at the end, you are doing the final assessment in the form of statistical analysis. Okay, now look at this and tell me what will be the correct order. Order will be this comes first, right? Followed by this, right? Followed by blinding, and then the fourth one. So this will be the correct order. In a village, they are screening. They mean someone, I don't know, are screening family members of a patient with hypertension and diabetes. So which type of screening is that? Is the question. Which type of screening? The question is about type of screening. Based on the subject in which you do screening, we have mainly three types of screening. I don't have to teach you what it is. You already know. Moreover, if you haven't heard about it, just The term itself is self-sufficient mass screening. Then you have high-risk screening and multiphasic or multiple screening. Now, what do you mean by mass screening? As the name indicates, you are screening in mass. That means the whole population, irrespective of their risk factors. Then you have the next one, high-risk screening. As the name indicates, here you are screening for diseases among those who are having some risk factors, like some family history or smoking, alcohol, whatever. Some risk factor, they have risk factors. So they are group having risk factor. Then you have multi-facing or multiple. Multiple means, as the name indicates, more than one, right? So here, as the name indicates, you are applying more than one test simultaneously in a individual or in a group of individuals, as in the case of annual checkups. Annual checkups, or your executive checkup. They are applying 10, 20 tests all together to find out some disease if it is there. Okay. So, what do you think is the answer here? They are doing screening among family members of a patient who was having hypertension and diabetes. So, there is family history. So, it is high risk screening, right? Oh, so simple question. What about diseases? Nothing more, nothing less. You know the answer. It is hepatitis A, right? No, who doesn't know that? Everyone knows it is hepatitis A. Whereas B, C, and D are getting transmitted through blood and blood products, right? So they are kind of similar, whereas this is something that you get out of waterborne. Not a high risk group in HIV sentinel surveillance. This we have discussed just before the exam when I did a 2020 series. There also I have discussed this, which is not a high risk group in HIV sentinel surveillance. Truck drivers, MSMs, IV drug abusers, female sex workers. Do you know what is HIV sentinel surveillance? We have already seen few MCQs from HIV sentinel surveillance. It is a biennial. It is done once in 2 years. Here, you're not only looking for HIV, but also for syphilis, HPV, and HCV. This is new, kind of new. And there are 8 population groups. Okay. And which are those 8 population groups? I'll show you the 8 population groups. Pregnant women, female sex workers, men having sex with men, injectable drug abusers, transgenders, male, single male migrants, long distance truck drivers, inmates at central prison. These are the 8 groups. Now you are all the more confused because all these or all those 4 options that I have shown you are under the 8 population groups that you do in HIV central surveillance. So how come you have an answer there? Guys, you know what? See, in HIV sentinel surveillance, I have clearly told you before as well that we are dividing the population into mainly 3 groups or 3 categories where you're trying to assess the prevalence in these 3 categories. One is, of course, high risk group, no doubt about it. Second is general population. And the third is known as bridge population. That means something which is acting as a bridge, or, what is bridge? Connection between the high risk group as well as your general population. Do you see any general population here? We have a proxy of general population, which is actually a part of the general population, who are willingly giving their blood for testing HIV, HPSAG, HCV, and all. Who's that? Pregnant women. So pregnant women are taken as a proxy of general population. Okay. Whereas we have the second group, which is female sex workers, males having sex with males, injectable drug abusers, as well as transgenders who are coming under the name high risk group. And we have the next 3, which are male migrants, single male migrants, long distance truckers or truck drivers and inmates of central prison, who are known as bridge population. Is it clear? You should be knowing this. All these 8 groups are not the same category, but they are coming under 3 different categories. Now let's go back and see what is the answer. The answer is truck driver, right? Because that is coming under not high risk group, but under the bridge group. Whereas MSM, males having sex with males, IV drug abusers, and female sex workers are high risk groups. Okay. Which of the following is not included in criteria for severe acute malnutrition? Severe acute malnutrition. So that brings you to the next question. What is severe acute malnutrition? And I hope you know it already. There are mainly 3 criteria to be satisfied in severe acute malnutrition. If you want to say that a child is severely malnourished or severe acute malnutrition, it has to satisfy mainly 3 criteria. One is very low weight for height, which is Z score less than -3 standard deviation. This is something which they always ask. Then mid-arm circumference. It is less than 11.5 centimeter and presence of nutritional anemia. And some even say that the presence of marasmic kwashiorkor, that means features of marasmus and kwashiorkor, can also be regarded as severe acute malnutrition. So let's see, what is the answer? Low weight for height, it has to be there. Pedal edema, yes, that is also pedal means nutritional edema. Yes, that is also there. Low height for age, what is it? Low height for age is not acute but chronic malnutrition. This is chronic malnutrition, which is nothing but stunting. So what is the answer? Guys, here the answer is low height for age. That is not coming under SAP. Cotton swab with pus is discarded in something which is very much expected, right? No exam will go without a question from biomedical waste management. This is very, very simple. Where will you put cotton with pus? You got it right. It is yellow. I'm not going to discuss it once again. We have discussed it 1,000 times. Okay. So 1,000 will be an exaggeration. So 100 times. Whenever I discuss, I always use this table. So you know about it, right? We have yellow, red, white, and blue. In yellow, we are putting contaminated waste, which needs to be incinerated. In red, you are putting recyclable waste. And I have told you how to remember recyclable waste. RPT. That means all rubber items, plastic items, and tubes you put in red. Then in white means it is translucent. There you are putting sharp waste because you should be able to see what is inside from outside. Then in blue, you are putting broken glasses and metallic pieces like, pacemaker, some implant, dental implant, ortho implants, all these things you put in blue. So whereas cotton or soiled waste it is coming under yellow. So all those waste you put in yellow and finally you incinerate. Whereas red ones you recycle. One more question is there, but I haven't got any options for this. I got the correct answer, but I don't know what is the option or what were the options. Which among the following is a major challenge posed by our country in providing universal health coverage? And students said, Madam, there was a long answer. There was a lengthy answer, and we were quite sure that that was the answer because all the rest of the options didn't make any sense. They didn't tell me what the options were. So they said the major challenges, the answer was giving affordable, accessible, essential services due to lack of resource. And everyone were like, Madam, this is the answer. We are very sure this is the answer. What were the options? Oh, those were, illogical questions or options. So this is the answer. So I'm also considering, or I'm also, assuming that what they have said is correct. So this was the answer. In a country like India, where we don't have much resource, giving affordable, accessible, essential care is something which is difficult. So these were the questions, and I hope this session was useful. So I have got around 18 questions, I think 18. Yeah, 18 or 19 questions I have already discussed. So there might be obviously more than 20 questions from PSM. As much as I got already in the initial few hours. I have updated. And if there are any extra questions, like I said earlier or in the beginning, please WhatsApp me, or you can even get in touch with me through my Insta ID, or at least you can comment those extra questions in the comment box below this link. Okay, guys, so all the best and thank you very much for your patient listening. If you have any doubt, this is my WhatsApp number. Okay, I'll be available. Bye.